Well, welcome everybody. Nundiandu from Ngarrindjeri country, and wherever you're listening to this from, welcome to the race grand round. And it's a delight today to be able to welcome Professor Shelley Nowlan as our guest speaker to the Riverland Mallee Coorong, and to be able to hear the wisdom that has come from over 30 years experience as a rural nurse, and more recently as the chief nurse and midwifery officer for Queensland Health, and recognised nationally as the Deputy National Rural Health Commissioner for Nursing and Midwifery. I've also known Shelley in her role with Rural Wonka, a pathfinder and a trailblazer as a non-medical person, being part of the rural health work of the College of General Practitioners in Akron. So thank you very much, Shelley, for visiting us today virtually, but I believe you are in South Australia, so that's great. Welcome, Nundi Andu, and we look forward to hearing your presentation and then some time for some questions afterwards. Thank you.
Thank you, Paul. I'll just ask Tash to share my screen, but a wholesome welcome to everyone. And yes, I am in South Australia, visiting family here for Easter, and I've had the pleasure of getting some fishing off the York Peninsula at Port Vincent, and managed a few crabs and some squid. I also travelled across to Drossen and a few of the other areas on the way. So good morning, or well, good afternoon now. I'd like to acknowledge the Kurana, Najaduri and Narunga people as the traditional custodians of the land where I stand today. I pay my respects to the elders past, present and emerging. And I'd also like to acknowledge the Aboriginal and Torres Strait Islander professionals that may be here today, and may your achievements be celebrated and our professional generosity support the work that you do. I'll ask you to move to the next slide, Tash. So today I'd really like to share a little bit of information around the role of the National Rural Health Commissioner. Next slide. The main role of the Commissioner is to achieve the goals and priorities that are set out by the Minister for Regional Health. Now, I'm of the understanding that you have met Dr. Ruth Stewart, and Ruth presented to you earlier in the year. Our office is a statutory office and has been appointed under Part VA of the Health Insurance Act in 1973. And as you know, Dr. Paul Worley was our first National Rural Health Commissioner, and that's where I had to, got the privilege to do some early work with Paul in Wonka. The other thing that our office does, with the next slide please, Tash, is that we engage with rural, regional and remote stakeholders. So again, thank you for your invite today. From my perspective as the Commissioner that's representing nursing and midwifery, we work very closely with the Australian College of Nursing, CATSANAM, Krana Plus and many of the other key stakeholders. The final thing that we do, and Tash, I'll get you to move to the next slide, is to maintain a strong policy focus on the health needs of rural communities. And we can only do this by engaging with you as we are today, and also to understand what it is like for consumers in rural remote communities, and particularly the workforce that work within them. Moving to the next slide, Tash. The work of the Commissioner and the Deputy National Rural Commissioner, there's actually two of us. One is Dr. Faye McMillan, and Faye is a pharmacist. She identifies as Aboriginal Torres Strait Islander, and she represents the work of Allied Health. Myself, being the second commissioner, represents nursing and midwifery, and my role is really to support urgent and emerging issues that may be occurring within the profession. And of course, at the moment, we've been seized by COVID, so some of our work has been working very closely with rural and remote populations to deal with COVID. This picture here is myself working in Normanton in 2020. Towards the end of the year, I went up and worked in Mount Isa Northwest Hospital and Health Service for a month, and I went out and fatigued the staff that were in Normanton, and a group of us, there was about 4 of us, went out and we worked there for 4 days and then went up to Karumba to also give some respite to those nurses. We through our work, we promote multidisciplinary trials, and particularly around primary healthcare is the work that we've been promoting at the moment, and also assisting all of the other departments within the Commonwealth and the state to provide strategic policy advice and stakeholder engagement. Tash, I think, yeah, we're back on the right slide. And also any specific projects that are undertaken by the office at the request for the minister. Moving to the next slide. The nursing workforce, as I mentioned, and midwifery workforce is where I'm focused on today. I'm actually going to speak about nursing. This next month in May, on the 12th of May, we have International Nurses Day coming up, and the 5th of May is International Day of the Midwife. Next slide. I guess the biggest question on our lips at the moment is, how do we ensure that nursing and midwifery are sustainable and are fit for purpose into the future? And how do we actually adjust how we attract, retain and support that skilled nursing workforce within the communities that they live? The old adage of just advertising is not enough anymore. Whilst Australia has got a population rich in nurses and midwives, there is a maldistribution, just like our GPs, of where they live and where the work is available to them. Next slide, please, Tash. What we've been focusing on is moving towards what you have as medical officers and allied health in regards to working on nurse generalists and ensuring that a fit for purpose rural nursing workforce is one that works to top of licence. This gets a little bit tricky in all of the different jurisdictions because our legislation in some cases actually restrict us to working to our fullest scope, particularly around drugs, medicines and poisons. Next slide, Tash. We have also focused on the development of a rural and remote nurse generalist framework to assist future rural nurse careers and opportunities. And this is the main work that I'm undertaking at the moment within the office. I work 1 day a week with the team, and we have worked with peak key stakeholders to ensure that we have the correct advice and really ensure that we're on the right process of laying out the capabilities required of registered nurses and rural and remote setting workforce, including that defining competencies where they can grow and develop. Next slide, Tash. So here I've got a slide that I just wanted to depict between 2014 to 2019, just the growth that we have had within all of the workforces of GP, midwife, pharmacy, nursing and other allied health. And as you can see, we've had very slight increases in the growth of the workforce working in MM1 to MM7. Where we would like to really concentrate is efforts around policy of how we can attract, retain, and also encourage people to work in rural and remote areas. And one of the things that has been successful around policy in some cases for GPs is the grants of HECS fees if working in those areas. That's now been again opened up further by the national government and includes nurse practitioners in this case. Next slide, Tash. So Australia can, next slide, you might have to push a couple of buttons here. Keep going, Tash. I think there's about 7 of them. Thank you. So Australia has been shifting its focus to the social determinants of health, and we know that that influence about 80% of health outcomes, 40% from a socio-economic point of view, 30% from health behaviours, and 10% from environment. We also know that this includes encouraging healthy behaviours and supporting communities to implement localised solutions to address their social determinants for health, and particularly for First Nations people and vulnerable groups, particularly from early childhood and those that are socioeconomic privilege is not the same. We, again, are working very closely with groups such as Krana Plus, CATSANAM, from a nursing perspective to ensure that we can provide the right care, place and time, and noting that as we become more rural and more remote, often the nurse and or midwife are the only healthcare practitioners in those areas, but they are also the only partners for GPs that live within that town, nurse practitioners and allied health. And if we're going to continue to focus on right care, place and time, keeping people healthy, we do have to engage with the consumer. And nurses are well placed to do that. They are well trusted within their communities, and often those that can support GP shared care within those communities through digital telehealth mechanisms, and also enabled by AI analytics. The collaboration is significantly important to ensure that we have a workforce that is fit for purpose, and the workforce of the future is one that absolutely works to their fullest depth and breadth of knowledge and skill that they have, and as I mentioned, top of license. So when I talk about top of license, it means that a registered nurse from the time that they are fully qualified and registered are enabled to broaden their scope and move very quickly into advanced practice. And some of that advanced practice is now expanding to surgical assist and anaesthetic assist type roles, particularly in rural remote areas, to support GPs who have extended generalist skills, particularly around surgery. And again, those outcomes generally in rural remote areas are on base funding or protected funding, and how do we go down this path to ensure that all practitioners that work in that area have some source of funding so that they can expand to be advanced practice. And this is the debate that's going on at the moment around Medicare. Next slide, Tash. We also therefore come back to why is it important to promote a national rural and remote nurse generalist. It's important because we are working in isolated environments, and like GPs in those towns, really thrive when we have a network of support, and we also thrive when we know that we have a pathway to gain the appropriate education and training that can support new models of care and enable the right talent and skill for the future, and leverage as much as we possibly can around education, training, mentorship, and in particular how we can advance the use of those skills. So within my role, I've stood up a steering committee comprising of the peak nursing professional bodies. They have provided us on a significant advice, focusing on development of a framework, problem definition and consultation of how we would progress through that. We have got representatives from the Chief Nursing Midwifery Office, Australian College of Nurse Practitioners, Australian Primary Healthcare Nurse Association, the Council of Deans of Nursing and Midwifery, support from James Cook University and the Australian Nursing and Midwifery Accreditation Council, the Nursing Midwifery Board of Australia, and then some key organisations as mentioned before, Krana Plus, Katsanam, and the Australian College of Nursing. Next slide, please, Tash. So the intent of the framework is similar to that of medicine, and it's to describe the unique context of rural and remote area nursing practice, where in many circumstances nurses provide comprehensive primary health care in distinct environments in very small teams. We have been focused on progressing the framework in the context that it provides us as nurses a guide to expand in different domains of practice. It also supports the employer and the organisations that support rural and remote nurses. Next slide, Tash. The framework is designed as a tool, and it has been built or underpinned by the 7 registered nurse standards of practice that are outlined by the Nursing Midwifery Board of Australia. The team has come up with 4 domains of areas where we absolutely believe need to be strengthened for the rural and remote nurse around cultural safe practice, critical analysis, relationships, partnerships and collaboration, and capability for practice. We have progressed to the stage now that we have developed capability statements under each of these domains. There's approximately 3 capability statements for each domain. And we have also progressed with developing capabilities. So when we talk about cultural safe practice, this is about knowledge and understanding of how one's own culture, values, attitudes, assumptions and beliefs influence interactions with people, families, communities and colleagues. The critical analysis domain focuses on the assessment, planning, delivery and evaluation of safe, quality, person-centred, evidence-based, individual care and population and public health care programs. The domain around relationships, partnerships and collaborations is about engaging professionally in a culturally safe way with open engagement with people that we work with, the person that we're caring for, and the full range of care partners to ensure that there's effective delivery of holistic comprehensive care. And the capability for practice is really about being able to demonstrate accountability and competency for their practice, being able to respond constructively to the circumstance and the unique context of the care provision that they may be providing as a health professional, and also their contributions to the multidisciplinary and interdisciplinary teams of practice. Next slide, Tash. So where are we at with the National Rural Remote Nurse Generalist Framework? As I mentioned before, we have gone out to consultation at Tier 3, which has now included other organisations outside of nursing, which has included ACRM, the AMA, we've gone to allied health associations and some of the colleges. We have received strong support from the rural and remote nurse of the need to have the generalist framework. We have also received strong support from our organisations of different professional disciplines and colleges. We're now refining the capability statements and the capabilities to, I guess, inform our master document, and also to ensure that the feedback that we have received has been taken on board. We received 147 responses through the online consultation website, which was just fantastic. And some of those organisations also provided separate and additional responses by email. As I mentioned before, we are now theming the feedback that we have received to refine and further improve the capabilities and capability statements. We have got support for the domains that we're using, so we won't be changing them. And I'll be fortunate enough to work in Adelaide tomorrow with my colleagues from Katsanam, Krana Plus and the ACN to finish that body of work. The final work that we will then do with this, next slide, Tash, is to continue to work. As you know, we're in caretaker mode, and caretaker mode, we will basically be understanding feedback going back to organisations for clarification, but we will not publish the framework until after the election and we have a new government formed who approves of the work that we've undertaken. Next slide. We will then finalise the engagement and promotion of the framework via nurse peaks, clinical educators, rural health services and employers, and also like-minded organisations as yourselves and the different associations in regards to our comms strategy. And from a longer term perspective, we'll be focusing on lobbying and working with government to then develop a nursing rural generalist pathway that the framework will then underpin a pathway to ensure that we do have a fit for purpose workforce for rural and remote communities. So with that, I think that gives you an update, Paul, of my role and the work that I have been undertaking 1 day a week. I'd love to be doing more, but at this point in time, we're now 9 months into the role of having a Deputy National Rural Commissioner for Nursing and Midwifery, and I have been fortunate enough to be extended for a further 12 months. So I'm happy to take any questions and general chit chat, Paul.
Right, thank you so much. That's brilliant. While people are looking for questions, and I can see ones come through, I'll just ask a question that's often confronts health professions of all types, and that is, in rural areas, aren't we all generalists?
We are all generalists, and then in nursing, moving through an advanced practice component, we then become specialists in some of those areas of generalism. So this is where we're now seeing, if we want a fit for purpose workforce for rural and remote communities, there may be a GP that has surgical skills and would like to undertake minor surgery and or some of those emergency surgeries such as appendectomy, and or they may be also obstetrics and wanting to do caesarean sections, expanding that generalist approach to surgical assist nursing and anaesthetic assist nursing will keep our GPs within those environments, whereby that they can broaden and work to their top of licence and full extent of their qualifications.
Thanks, Shelley. Andrew Olesnicki is our Director of ED in Berry. Andrew, you're on mute.
Hello, Shelley. Thank you for that presentation, and thank you, Paul. Yeah, look, that is a very exciting thing that's coming along for our nurses in rural areas. Absolutely. Can I just ask, is it the framework and the credentialing, sort of the clinical credentialing? Is it just one credential that you either have or you don't have, and you can or you can't perform or do or undertake certain things, or will there be different specialties within this rural generalist sort of framework?
Yeah, so the framework actually supports that of our qualification as a registered nurse under the Nursing Midwifery Board of Australia.
Yeah.
What we're finding is that our different states and jurisdictions have different ways they provide clinical governance around the work that nurses and midwives do. The framework won't actually be a credential or a qualification. It will be a tool that assists the nurse who wants to transition to rural and remote nursing practice on where they need to hone their skills or further develop the breadth and depth of their work that they do. So coming out as a registered nurse, I can work in any of the specialties, mental health, emergency departments, medical wards, general wards. But what defines our safety approach around our practice is our own scope of practice. And this is where we need to, under our licensing, be able to demonstrate that we have competency and capability to work under certain scopes of practice. Now, because when you go into rural remote areas, as you know, 1 minute you may be working in the emergency department, then you may be in aged care because you're a multi-purpose health service and you have aged care residents within your hospital as well, or you may be in a primary health clinic doing vaccinations. What the framework actually does do is support either an employer to say this is the education that you should be supporting your employees that work within these environments. It supports university educators or educators within hospitals of if this is the environment that your nurse is working in and there's emergency there, there's mental health, there's aged care, they should be developing further their capability of working across all of those streams. When we came out in hospital training many years ago, we would have had the opportunity to work in all of those environments over the 3 years through clinical practice in those environments. Now that we are in university hospitals, we're finding it even more difficult to get a rural placement and or a placement in each and every one of those areas that a nurse can work. So we are also finding that your first 12 months out as a registered nurse, you generally start to feel comfort in that first 12 months of wherever you get your graduate year, and you therefore are not likely to be moving across into regional and rural areas. Therefore, the framework will help support the confidence of nurses to move into those environments.
Yes, yeah, absolutely. I mean, I guess as a sort of, well, veteran of 12 years of remote and rural practice, that idea of, you know, operating at top of license quickly it's a delightful thing as an employer and as someone who's trying to provide a service, but also someone who's trying to retain staff. There's also a bit of a caveat there where it can scare off a lot of junior staff who are not quite ready to operate at the top of their license. But out of necessity, because of their rural or remote location, often are put into a situation where they're forced to operate in that sort of in that capacity. And can I just ask another quick question? This is obviously a federal project. This is a federal position. Is this something that you anticipate will still need to be accepted or endorsed by the different states, or do you anticipate that with consultation with the individual state health services, once it is finished, published, offered to whoever it's to be offered to, that it will be a kind of a national credential, if you like, or a national framework or something that as remote and rural clinicians who travel a lot, which is what they do, across state borders, that will be recognised, and what they've done in another hospital across this border, they can take their portfolio of competencies and immediately be allowed to function in that capacity in some interstate hospital.
Yeah, Andrew, this is the very first step of us going on the journey that medicine has around their rural generalist qualification that they have got.
Yeah.
It is an aim to be a national rural and remote nurse generalist framework. The peak bodies that are sitting on our steering committee are national peak bodies that, like, for example, the ANMF represents all of the unions across our states and territories. The chief nurses and midwifery officers of each of those jurisdictions have been consulted and have brought back to us very valuable feedback in regards to support. There is absolute strong support for this to be a national framework. It will be the first of any country to have a framework for nursing and midwifery to this context. We are taking our time around the consultation so that we do get it right. And then once we have the framework endorsed and published, we will then continue working with those peak bodies to say, now, what does the pathway look like? And my aim is really probably to join up some of the work that's already funded from a Commonwealth perspective with Prana Plus and the Australian College of Nursing, and to see if we can make fast tracks with education programs that they already have in place, and that we start to map out the pathway very similarly to what medicine and allied health has. But given the, if you have a look at the nurse's role, there's such a breadth and depth of expansive practice and skill sets that we actually do. We don't want it to be dictatorial as well. And we don't want to actually restrict practice by saying, well, okay, last month you had the competence check, tick. This month you haven't had the opportunity to get re-evaluated, so you're no longer competent. We don't want to go down that pathway. We want to go down the pathway that your scope of practice is determined by the nurse working at the time, and that there's organisational credentialing that is provided by the employer. Yeah. So this is not a qualification or a license or something that you have to show. It is essentially a guide, a tool, a framework that we expect people to lift and to expand, working under much of the legislation of each of the state jurisdiction that they work in.
Shelley, thank you,
Andrew. Yeah.
Thank you so much. Thank you so much for that. Sorry our time is out. Otherwise, there would be a lot more questions, I'm sure. It's been wonderful to hear these developments. Very apposite for us as an academy and as an LHN looking to be accountable for our own education and training of our workforce. And so we will look to this framework to guide that. Thank you very much for the work that you're doing, and also for the inspiration that you are to so many people. A rural nurse who can still work in modified Monash 7 environments and be guiding our national policy agenda. Thank you so much for that work and for spending this time with us here this afternoon in South Australia, in the beautiful land of the Riverland, Mallee and Coorong.
You're welcome, Paul. And don't forget, next month, International Day of the Nurses and International Day of the Midwives. And I'd be more than happy later on in the year to join with you about update about midwifery, if you like, as well.
Thank you very much. And thank you, everybody, for another grand round. We look forward to seeing you in a month's time. Nowlan.
Thanks, Shelley.
Nowlan.
Thank you.
And everyone else.
Thank you.